One, please start, sir.
Yes, sir. Sir, good evening, sir, and good evening, distinguished delegates and our eminent speaker. I, Raju Bonakoluru, honored welcome to you, sir, this scientific digital platform called TimeTalk. Doctor, on behalf of Zydus Life Science, I would like to express my most sincere gratitude for presence this scientific webinar. Giving you all a small brief, a TimeTalk is one of the initiative of Zydus, which is encompassing one more concept of diabetes management. As you know, in India, 10.1 crore population are diabetic, which leads a various cardiometabolic complication. And for that, so many therapeutic molecules and FDCs and management options are available, which keep on evaluating over a period of time. Hence, today our eminent speaker, Dr. Quadri sir, he will taking the session novel agent T2DM armamentarium. Please hand over to you, sir. Thank you, sir.
Good afternoon, everybody. Thanks you for the excellent introduction, sir. I'm Dr. M.A. Muqsith Quadri, a consultant physician and a diabetologist. I work at Care Banjara, Hyderabad, as a consultant physician, and I also have my own daycare center, Expert Medical Center in Hyderabad. So today we're going to talk about a new group of drug that is creating a new wave in the type 2 diabetes patients, and it has been studied a lot, and I'm one of the members in the study. And this is a dual action marvel in type 2 diabetes. It is imiglamin. So next slide, please. So, as you can see, the burden of diabetes in India has been consistently increasing in the last 20 to 30 years. And with diabetes, the other um, non-communicable diseases are also causing a lot of problems. And when the diabetes starts, it brings along with it its friends like hypertension, abdominal obesity, hypercholesterolemia, and all that. So next slide, please. So what are the challenges in type 2 diabetes management? So basically we have to look at two things. uh, as I explained to my patients, what's the problem with diabetes? It's not everybody thinks it's just high sugar. No, it's not. It is decreased production, that is beta cell dysfunction, and increased insulin resistance. So most of the drugs that we use either work on the beta cell dysfunction or they work on the insulin resistance. Next slide. An overview of the mitochondria. Type 2 diabetes is characterized by a metabolic imbalance in which the ATP levels are compromised and mitochondria play a major role. Three major functions of the mitochondria relevant to diabetes is ATP production, generation of the reactive oxygen species, the ROS, and apoptosis. Next slide, please. So mitochondrial dysfunction will lead to a bunch of things. What will cause mitochondrial dysfunction? It is increased lipids. There are environmental factors like obesity, intrauterine issues, or pollutants, and imbalanced mitochondrial protein acylation, and some DNA mutations. So this mitochondrial dysfunction will lead to decreased mitochondrial biogenesis, hence decreasing ATP, leading to cardiac dysfunction. ETC leakage leading to mitophagy and apoptosis. Lipid accumulation acting on decreased insulin action, and all this will lead to decreased insulin production, decreased stimulating secretion coupling, and with the reactive oxygen species overproduction will cause cellular injury and antioxidant capacity decreasing, leading to decreased beta cell mass. So hence there is decreased insulin secretion and decreased insulin resistance, which leads to diabetes. Next slide, please. So influence of the oxidative stress on mitochondrial dysfunction, insulin resistance, and diabetes is depicted in this photo. The mitochondrial dysfunction will reduce insulin-stimulated glucose transport. The oxidative stress will decrease transcription factors, leading to decreased insulin resistance. and the insulin receptors also needing ATPs will cause a decrease in glucose uptake and metabolism, which all leads to diabetes. Next slide, please. The effect of the reactive oxygen species accumulation on mitochondrial function. When these increase, they cause DNA structure modification, leading to PDX destruction and decreased insulin expression. Also, act on cardiolipin oxidation and cause apoptosis. And protein, lipid, and carbohydrate oxidation decreases, and all these lead to diabetes. Next slide, please. The mitochondrial is just what I've just told. The accumulation mitochondrial impairment will lead to accumulation of ROS. This will lead to apoptosis, will lead to decreased insulin expression and decreased oxidation of the protein, lipids, and carbohydrates. PDX is pancreatic duodenal homeobox. Next slide, please. Increased fatty acids in mitochondria lead to decreased function, leading to increased insulin resistance and reduced glucose uptake. Next slide, please. This is a brief overview about mitochondrial biogenesis. The mitochondrial quality control induction of mitochondrial biogenesis causes selective removal of damaged and redundant mitochondria. So, promotion of cell survival, cell reprogramming, cell differentiation and development, control of inflammation, and maintenance of redox balance. The physiologically, it will help in improving it, and the pathological conditions will decrease this condition. Next slide, please. So, decreased mitochondrial biogenesis cause increased mitochondrial production of ROS. We know what happens with that beta cell dysfunction. The mitochondrial damage resulting in reduced production of ATP will cause insulin deficiency. And the mitochondrial release of pro-apoptotic factors will cause again beta cell mass loss. Same thing is depicted in the pictures. Next slide, please. So, main effects of our currently used hypoglycemic agents. One is the bigonads and thiazolidinediones, which increase peripheral glucose uptake in the adipose and skeletal tissue. The ones which are secretagogues, the insulin secretagogues, are sulfonylureas, metagonides, and exogenous insulin. The kidney, it helps with the SGLT2s, decrease glucose reabsorption, the glucose introduction by bigonads and thiazolidinediones, and glucose absorption by alpha glucosidase inhibitors in the intestine. Next slide, please. So, what is the need of the R? It is something that acts on both the insulin synthesis and insulin resistance. This imiglamin is a new group of oral tetrahydrotriazine compounds. Next slide, please. A drug with a dual mechanism that is designed to increase insulin secretion in response to glucose and to improve insulin resistance. It was approved novel drug. It is an approved novel drug for type 2 diabetes with a differentiated mechanism of action. It's approved in Japan in 2021 June, and was the first Japan was the first country to approve and use imiglamin. It has also been approved by DCGI, and it has been supported by numerous preclinical and clinical studies. Phase 3 times trial program jointly managed by Poxol and Sumitomo Dai Nippon Pharma. It's the only oral compound with a dual mechanism of action that is directly designed to both increase insulin secretion and response to glucose and to improve insulin resistance. Next slide, please. The effect of imiglamin on mitochondrial energetics and the consequent effects on the liver, pancreas, and skeletal muscles. So the imiglamin acts on the mitochondria, and this causes increased muscle insulin resistance. Decreased muscle insulin resistance and decreased reactive oxygen species, leading to increased glucose utilization in the skeletal muscles. It increases the liver mitochondrial function, hence decreasing ROS, and decreasing gluconeogenesis and increasing glucose utilization. And on the pancreatic beta cell, it increases the beta cell function and decreases ROS, again causing increase in insulin secretion and decrease beta cell death. Next slide, please. So that's what it's a both insulinotropic and an insulin synthesizing properties. So the mechanism of action, it acts on the NAMPT, which converts nicotinamide to NMN and NAD plus, which acts on the mitochondria and increases ATP to conversion, ATP to ADP conversion, and then it also acts down pathway, causing insulin secretion on the beta cells by the ADP and CADPR mechanisms. Next slide, please. So the mechanism of action from other cellular metabolic pathways increases NAMPT and NAD, causing increases calcium mobilization, which partially inhibits complex I-55, reduces ROS formation, restores complex 3 function, prevents MPTP opening, and hence lessens release of pro-apoptic proteins and increases ATP generation. This leads to improved beta cell function and beta cell protection, and enhances insulin action on the liver by increasing gluconeogenesis and decreasing steatosis, and muscle increasing insulin signaling and glucose uptake, increasing glucose uptake. Next slide, please. So the molecular mechanism which hemoglobin improves glucose homeostasis, insulin sensitivity is increased, and resistance via molecular pathways as promoting AKT phosphorylation, modulates genes in hepatic gluconeogenesis and causing declining gluconeogenesis. Beta cell functions it's protective on the beta cell, causing decreased beta cell death, increasing beta cell mass, and improving glucose induced insulin release from the islets. And mitochondrial function, it is improving and oxidative stress by reducing the ROS. Next slide, please. So what is the imiglamin mode of action versus metformin? It has a glucose stimulated insulin secretion where there is none in metformin, and it has a this is both seen in vivo and sorry in clinical and preclinical data. And cell and organ glucose stimulated insulin secretion from the islets and the perfused pancreas and islet B cell protection, preserve beta cell mass. There is no effect on glucose stimulated insulin secretion, and muscle glucose uptake is seen in both. Next slide, please. Intracellular. Uh, this acts on mitochondrial complex. It acts on increases NAD synthesis via NAMPT and increases glucose responsive intracellular calcium. Metformin has uncompetitive mitochondrial complex 1 inhibition, decreased respiration, and decreased ROS formation. There is no increase in the calcium response via the glucose responsive intracellular calcium channels. Next slide, please. Pharmacokinetics. Oral drug can be taken up to 1000 milligrams twice a day, has a very low protein binding, very low hepatic metabolism. It is a urinary excreted drug, hemoglobin clearance driven by creatinine clearance. There is no drug-drug interaction with metformin, sitagliptin, and cimetidine. There is no QT prolongation. There's no differences between the pharmacokinetics in Caucasians and Japanese subjects, and there is no food effect. Next slide, please. Half life is about 10 to 20 hours, and bioavailability is dose dependent and ranges from 20 to 50%. Hemoglobin is not metabolized, it is eliminated unchanged in the urine. Next slide, please. Special populations. As per innovator, no clinical trial will contain patients with moderate or severe renal dysfunction, that is EGFR less than 45. Using efficacy, administration is not recommended. Hepatic patients, SOIF, and well tolerated in patients with moderate hepatic impairment. Clinical trials obviously have not been done with severe CP classification C patients. Should not be administered in pregnancy. Lactation continuing, personally avoid, as transfer to milk has been observed in animal experiments, avoid using it during lactation. Not a question whether we can continue or not. So imiglamin's effects on insulin secretion and sensitivity. It has an insulinogenic effect on the glucose, and the effect of imiglamin on insulin sensitivity, it shows comparing to a placebo, it's very high. Next slide, please. Imiglamin increases glucose dependent insulin secretion and improves beta cell patients with type 2 diabetes. The aim of the trial was to assess the glucose stimulated insulin secretion and effect of imiglamin. It was a double blind randomized placebo controlled trial in 33 patients who were drug naive or withdrawn from their previous metformin therapy. Imiglamin treatments given for 7 days raised insulin secretory response. First phase by 110%, second phase by 29%. It showed improved beta cell glucose sensitivity by 36% and tends to decrease hepatic insulin secretion. It did not affect the glucagon secretion. Next slide. Uh, in patients with type 2 diabetes, imiglamin improves beta cell function, which may contribute to its glucose lowering effect. Next slide. There was an absence of QTC prolongation in a QT study with imiglamin in a first class oral agent for type 2 diabetes. A thorough QT study was conducted to establish electrophysiological effects of the therapeutic and supratherapeutic doses of imiglamin on cardiac repolarization. A thorough study did not show any induction of a QT-QTC prolongation with a strong confidence as evidenced by the assay sensitivity. Next slide. Clinical data, months of studies have been done. Next slide. Um, this is a consensus statement from Japan Diabetes Society. Programmed algorithm for pharmacotherapy in patients with type 2 diabetes. Determine if the patient has the relative absolute indication for insulin therapy. No, then they went with with their HbA1c control goal. Select medications to address the diabetes pathology involved. So non-obese patients were given a bunch of drugs and obese patients were divided. Next slide, please. Times 1 trials of imiglamin for efficacy and safety. The aim of the study was to investigate the efficacy and safety of imiglamin in Japanese patients with type 2 diabetes. This was double blind, randomized, parallel group, placebo controlled phase 3 trial. They were 213 patients. Patients were above 20 years of age with type 2 diabetes, treated with diet and exercise, stable for greater than 12 weeks prior to screening, and whose HbA1c was 7 to 10. They were randomly assigned either to the imiglamin group, 100 milligrams twice daily group, or a matched placebo. The study was done for 24 weeks, and the primary efficacy endpoint was the change from baseline HbA1c at 24 weeks. Secondary endpoint, the percentage of patients reaching HbA1c target of less than 7, and percentage of responders as defined as the percentage of patients with relative degrees of greater than 7 from baseline at week 24. Next slide, please. So the primary endpoint compared with the placebo, the adjusted mean difference in HbA1c from the baseline was about 0.87. Secondary endpoint at week 24, grade less than 27% was achieved by 35.8% of the patients in the imiglamin group compared to the placebo group of about 7.5. At week 24, relative degrees of greater than 7 from baseline HbA1c was achieved by 57.5 when compared to the when compared to the placebo group who are only 11.3. Next slide, please. Times two trials was the this was to evaluate the safety and efficacy for 52 weeks as monotherapy or combination therapy with another anti-diabetic drug. It was a long-term open-label multi-center trial. 714 patients were selected greater than 20 years with diet or exercise alone or together with another anti-diabetic monotherapy. It was endpoint primary endpoint was safety to prevent see any adverse effect laboratory results ECGs. Secondary was changes from baseline of HbA1c at the week 52. Next slide, please. Results in HbA1c with the monotherapy using tablets were as above, greatest seen by with DPP4s and the least seen with GLP-1 receptor agonists. Next slide, please. Times 3 was a randomized double-blind panel group multicenter trial in 35 sites in Japan. Either they were given 100 milligrams twice daily or matched with the placebo in combination with insulin for 16 weeks. In the subsequent 36 weeks, an open label extension period, all patients received hemoglobin twice daily. The patients were 215, 52 weeks was the duration, and the primary endpoint was to see a change in the baseline from of HbA1c at week 16 with hemoglobin versus placebo in combination with insulin. Secondary were to see how many went below target 7 at week 16 and relative decrease of at least 7% from baseline at HbA1c of HbA1c at week 16. Next slide, please. So, mean HbA1c reduction after 16 weeks in hemoglobin and placebo group is shown. It was shown significantly decreased by 0.63% with hemoglobin at 16 weeks, that's 4 months, compared to the placebo when it is 0.03. And the difference versus placebo is zero point 0.6. Next slide, please. So, phase 3 clinical trial, Indian study. It's a multi-center, randomized, double-blind, parallel group, placebo-controlled, comparative, prospective, and phase 3 clinical study. This is for treatment-naive patient. Was treatment-naive patient. It was a 112 days duration study. Mean change in HbA1c was the primary endpoint, and mean change in the fasting blood glucose, mean change in the PPG at week 16, proportion of patients reaching HbA1c less than 7, and proportion of patients requiring other rescue medications. Next slide, please. Mean change of HbA1c from baseline to end of study visit was about 0.86%. And next slide, please. Mean change in fasting from baseline to end of the study visit is shown in the view. Placebo, there was not much of change, nearly minus 13 patients. And in PPG, there was a significant decrease. Next slide, by 13 points. So, meta-analysis. This research seeks to examine the management of the most efficacious and safe dose of hemoglobin for management of type 2 diabetes. Next slide. When given as monotherapy, hemoglobin 1000 milligram twice daily was associated with greater reduction in HbA1c when compared to a placebo. That was the first thing. Next slide. When given in combination therapy, it also did better than placebo. Next slide. There was significant drop in HbA1c. When given with monotherapy, hemoglobin 1000 twice daily was associated with better reduction in fasting glucose levels compared to placebo. Next slide. So the conclusion is there is no significant difference between the TEAEs, the SAEs, and other minor AEs when compared to a placebo. Other study suggests, our study suggests that the hemoglobin twice daily may offer the most optimum therapeutic effects for glycemic control without compromising its safety profiles. Next slide, please. So, what is the take home message? Type 2 diabetes mellitus is a widespread disease affecting a lot of people, nearly 380 million people worldwide. Currently, there are two challenges in management: insulin resistance and beta cell function. Beta cell dysfunction results from the inadequate glucose sensing to the stimulate insulin secretion. Therefore, elevated glucose concentrations prevail. Insulin resistance characterized by diminished response to insulin stimulation, resulting in failure of target tissues to adequately dispose of the blood glucose. Mitochondrial dysfunction also leads to type 2 diabetes. Next slide, please. Currently available already address only one facet. Imiglamin tries to take part in all three organs of the diabetes, that is the pancreas, the liver, and the muscle. They have shown to have a positive impact on the skeletal muscle glucose uptake, hepatic glucose production, and beta cell apoptosis decrease. Imiglamin demonstrated good efficacy with monotherapy and with combination therapy, best with DPP4 inhibitors. Thank you. Any questions?
Uh, no, sir. This closing remarks, sir. Sir, good evening, sir. It was
Good.
Indian pleasure and honor having you this event, sir. On behalf of Zydus Life Science, would like to extend our sincere thank you to you for your comprehensive session. We are sure our delegates and would have definitely got and regarding imiglamin as uses and covered all the possible aspects in your session. At the same time, we would like to thank you all the delegates for their presence and patience hearing. Thank you, sir. Thank you, one and all. Thank you very much, sir. Have a great evening.
Thank you.